to the voiceover for pre-excitation. So in the last few sections, we've talked about more of delays. So with our bundle branch blocks and heavy blocks and things like that, we're talking about the delay in electrical current. And pre-excitation is exactly what it sounds like. This is actually the opposite. It's now things are happening more quickly, so that electrical current is conducted to the ventricles more quickly than usual. So the heart has to deal with all of that. So we're going to go ahead and get started. The first slide, what is pre-excitation? So pre-excitation, there's two major types. So you'll have to know that for the exam, there's two types. One is called WPW, or Wolff-Parkinson's-White syndrome, and the other one is LGL, Levine or Levine syndrome. Those are the two that we'll discuss today. Now, the one that the book highlights more is the Wolff-Parkinson's-White syndrome, and this is where the accessory conduction pathway acts as a short circuit. So this allows the atrial wave of depolarization to bypass the AV node and activate the ventricles prematurely. So I'm going to say that one more time so you can kind of follow it, but we'll back up. With normal conduction, we know that there's that small delay or short delay between the atria and the ventricles in the AV node, where the depolarization wave is held up for that 0.1 seconds. And that gives the atria enough time to contract and empty the blood and get it into the ventricles. But with this excitation syndrome, there's accessory pathways developed. And that's when this current can bypass the AV node and arrive in the ventricles without delay and often ahead of time, which kind of messes up the timing of the heart. So Wolff-Parkinson's-White syndrome is the accessory conduction pathway that acts as a short circuit. So like I mentioned, that allows the atrial wave of depolarization to bypass the AV node and activate the ventricles prematurely. That is its definition. This can happen in normal, healthy hearts. You may also have issues. You may see it in conjunction, as the book says, with MVP, mitral valve prolapse, cardiomyopathies, congenital disorders, but you can also see it in normal hearts. So the most common, the one that you'll see the most, is this Wolff-Parkinson's-White. So let's head to the next slide, which discusses that in more detail. So the Wolff-Parkinson's-White's bypass, or that pathway, is called the bundle of Kent, and I'm going to show you another picture on the next slide. But for now, as I mentioned, it's a conducting pathways that connects the atrial and the ventricle. So it can be one of two things. It can be left-sided, which connects the LA and the LV, or it can be right-sided, connecting the RA and the RV. So when this premature ventricular depolarization through this accessory pathway happens in Wolff-Parkinson's-White, there's things that happen on the EKG that you can use to diagnose. So the PR interval changes. It's shortened. It's less than 0.12 seconds. And another thing that you'll see is you'll see a QRS widen to more than 0.1 seconds. And that's just due to the premature activations. And what you'll see is called a delta wave because of this. So that delta wave, you can see the picture of it. It's where the arrow is pointing in the slide. But that is a delta wave that you will see with Wolff-Parkinson's-White oftentimes that shows that QRS widened. Also, this area where you see that depolarization happening early with that delta wave gives that QRS that I don't want to call it, they call it in the book and I didn't write it down, but almost a slurred, maybe they said upstroke, and that's what that delta wave is, and that's just because of that early depolarization, as I mentioned. You may not see that delta wave in all of the different portions of the EKG, but that's definitely something to look for. Let's go to the next slide, which is a visual of the Wolff-Parkinson's-White syndrome. So here you'll just see that on the left side is the normal pathways that you're used to seeing during this semester of learning, and then on the right that shows that accessory pathway that the electrical activity actually goes through, and then it shoots across differently to activate the ventricle and so on during depolarization. So this is more a visual for you for that Wolff-Parkinson's-White. If you go to the next slide, here's just another example of how you'll see that delta wave. You'll notice on the third one, it's almost not even visual. It's very hard to see on some of them. So it's just obviously something that that you can catch, but sometimes you won't necessarily tell because it runs in with the QRS complex. And once again, why does this delta wave happen? Well, it happens because it's a result of a premature ventricular depolarization. So that would be your best answer for that. You would also want to see potentially maybe this delta wave. It would be evident. It wouldn't be one of the ones that merges with the QRS complex, but you might see a picture of that and have to say what it is on the final exam or maybe potentially a quiz. Let's go to the next slide. So you can have two different types of tachycardia that actually happen with Wolff-Parkinson's-White, or WPW. That would probably be easier for me to say. So it actually predisposes people to get these tachycardias. So the first one is PSVT, or the paroxysmal ventricular tachycardia. And with these, 50% to 70% of individuals with Wolff-Parkinson's-White actually experience this at least once. We do know that those forms of tachycardia do come with symptoms such as palpitations, shortness of breath. So that is something to keep in mind. So we have the supraventricular tachycardia, and AFib can be onset because of WPW. Now, the book goes into a lot of detail about these. I'll be honest. So with the supraventricular tachycardia, WPW, I think the important thing for you to take away is that there's the QRS during the arrhythmia is narrow at times because that ventricular depolarization occurs through the normal bundle branches. And then sometimes you'll also see the supraventricular tachycardia have a wide QRS complex, and it may look a little bizarre like we've seen because that ventricular depolarization does not occur along the normal bundle branches. So there's two different pathways or travels that it can do. I think what's important for you to know is that WPW can bring on two forms of tachycardia, one being PSVT. With that, you can have a wide or narrow QRS complex, and then also AFib is the other rhythm that can be induced. Sometimes this can actually be fatal, which is pretty insane. The accessory pathway can act as a free conduit for chaotic atrial activity. So they've even mentioned getting your rates up to the 300s for this. I can't even imagine. This is super rare, but it has been known to happen with people that have WPW. So those images that you see on that slide, the first one, or the one on the top, A, is the supraventricular tachycardia, and then B is the AFib that has that irregularity to it. So you can see the top one has that regular rate, whereas B is the not regular rate, irregular rate with the AFib. All right, and finally for this section, we have the Lown-Ganon-Levine syndrome. So the bypass in this one is called the James fiber. It's a pre-excitation syndrome of the heart, obviously. And those who have it have episodes of abnormal heart racing with a short PR interval and a normal QRS complex seen on their electrocardiogram. So that's just something to notice. See here. We know that the short PR interval is caused by that accelerated conduction through the AV node, just as it is in WPW. PW. So the difference is, well, we have that short PR interval. That's the same. But the two differentiating factors between the WPW and the LGL are the QRS is not wide on this, and there will be no delta wave as well. So those are kind of the determining, the differentiating factors from the Wolff Parkinson's White and the LGL. So that's really all you need to know as far as that goes. You can definitely get into some more information if you have any interest in this. I've seen it a couple of times in my experience, but at the time didn't know a ton about it. So the more I did EQTs, of course, the more you're going to come in contact with it, but it's not super common. So if you do experience it, definitely pay attention and look it up and learn from that EKG. Thank you.